Assalamu alaikum. I am Dr. Nas, and again we are here with a very peculiar, very important topic of cardiology, heart failure. Today we will first develop the concept of heart failure, then we will discuss about the different stages of the heart. First of all, obviously, we will discuss about the pathophysiology of the heart failure, and then later on about the stages of the heart failure stages, and how would we classify according to the symptoms of the heart failure, then etiology of the heart failure today. Okay, so first of all, what is heart failure? As you are looking here, that heart failure is basically, heart failure is a clinical diagnosis. If your patient has the symptoms of heart failure, which we will discuss later on, that if your patient has symptoms of heart failure, then obviously you will diagnosed and you will write in the diagnosis as the heart failure of the patient. But if your patient has no ongoing symptoms, if the patient, because heart failure is a basically most commonly used as a misnomer in the field of cardiology, and in our clinical practices we most of the time very frequently write down our patients in our clinic, asymptomatic patients in our clinic, as heart failure patients, because yes, they could be on the stage A of the heart failure, but ideally those patients should not be written as a heart failure patient, because heart failure is a clinical diagnosis and you have to write a diagnosis as a heart failure if your patient has the symptoms of heart failure, because it is a clinical diagnosis. Okay, and heart failure can be because of anything. Heart failure actually has two components. Okay, and heart failure has been divided in so many categories and so many classes. Right now just focus here that what is heart failure. Anything which makes heart incapable to push the blood into the system, like into the aorta, into the system, causes heart failure. Why? It obviously develops the back pressure and it increases the pressures in the pulmonary veins and causes the pulmonary edema. So your patient would go into the congestive heart failure because of the lack of pushing force, like anything which is making your heart incapable or incompetitive to push the blood forward. So that, and you can say it as a systolic heart failure as well. Got it? So anything, etiology could be anything, but your patient is in heart failure. Etiology might be because of like aortic regurgitation. Etiology can be because of aortic stenosis. Etiology can be because of your LV dilatation. Etiology can be because of any other cause like acute disease, cardiogenic or any other shock in which your heart is actually compromised and it cannot push the blood forward. Then you would say that it is a systolic heart failure. Then we will later on discuss about the causes and how it would occur. Okay, first of all, just develop the concept of heart failure. Heart failure can be because of anything. It is not necessary that it should be after ischemic event or anything. It could be because of anything. Okay, so, or this is the one thing that would be the systolic heart failure. Okay, now what would be the heart has to do, especially the left heart. This is the LV. This is basically LV, left ventricular, left ventricle, and that is the LA. Actually, your LA. This is the LA, and this is LV. Okay, here we are discussing the function of the left ventricle here. Okay, so anything which makes incapable LV to push the blood forward, we would say that it is a systolic heart failure because of anything we are not discussing here. LV has to do the two things. One, in systole, to push the blood forward into the aorta, into the system, and to take the blood from LA into the LV in diastole, which we usually known as like passive filling of heart. Okay, in passive filling of LV from LA in diastole. If your LV is incapable to get relaxed, here your LV was incapable to do the enough contraction to pull the blood into the system. Here your LV is incapable to relax. your LV is incapable to suck or to pull the blood from LA. So your heart failure would be obviously because of diastolic phase, because of the impaired relaxation of the LV, because your LV is incapable to be relaxed in the diastole, incapable to suck the blood from the LA. So that heart failure would be diastolic heart failure, and in that diastolic heart failure your systolic function would be normal, but obviously because of impaired relaxation your blood is not coming passively from this LA to LV, so your heart is obviously thickened heart because it is impaired to relax, it has incapability to be relaxed. So it would cause what? It would exertion, it would cause the increased pressure in the LA, and from LA it would increase pressure into the lungs and cause pulmonary edema. So heart failure can be because of two things, one is the systolic and second is the diastolic. Here we would discuss the things of pathophysiology of the heart failure with reduced ejection fraction. The heart failure with reduced ejection fraction, the meaning of the heart failure with reduced ejection fraction is that your patient is in the symptoms of the heart failure because of the reduced ejection fraction. So how would we divide heart failure into the classes? According to the AHA guideline, we have divide the heart failure into three classes according to the EF on the basis of contractile reserve or the contractile function of the heart, which we usually measure as the ejection fraction. So if your patient has the ejection fraction of less than 40%, you would say it's that your patient, if your patient is a heart failure, then you would say that this patient is HFrEF, or your patient has a reduced ejection fraction. Okay, reduced ejection fraction, you will diagnose your patient as a reduced ejection fraction if your patient has the ejection fraction of less than 40%. But if your patient has the ejection fraction of more than 50%, then you would say that your patient has a preserved ejection fraction, and the numbers between 41 to 49 is actually borderline heart failure, borderline ejection fraction. Okay, so now we will discuss here about the pathophysiology of the reduced ejection fraction, why your patients are presenting to you with the signs of heart failure and with reduced ejection fraction, and what would occur in this reduced ejection fraction. Most of the time with the reduced ejection fraction, the cavity of the heart would become dilated, would become bigger, and in diastolic heart failure your cavity becomes smaller because of the restrictive changes, because of the hypertrophic changes in your LV cavity, it causes the small cavity. But in the HFrEF, in the reduced ejection fraction, the cavity will become bigger. So now come to the point of the pathophysiology of the heart failure with the reduced ejection fraction. There are the three main things, there are the three main systems are involved to actually cause the reduced ejection fraction in HFrEF patients. So obviously, as you are very familiar with the term of remodeling, actually this is the pathophysiology, this is the basically mechanism of remodeling, because in HFrEF patients so many times you discuss that we have to prevent the remodeling by these drugs, or these drugs are preventing the remodeling, but we are not actually well aware about the remodeling. What is remodeling? Remodeling is nothing. Remodeling is a thing which remodeling actually causes few things in the myocardium cells. Remodeling actually causes one myocardial hypertrophy, fibrosis. Number 3 is apoptosis, and number 4 is necrosis. Actually, remodeling caused by these three systems, caused on molecular level in the myocardial cell, causes what? Myocardial hypertrophy, fibrosis, apoptosis, and finally necrosis of the myocardial cells. How it would occur? If your any injury to your myocardial cells by any reason, by ischemia, by inflammation, by infection, by any valvular abnormality, by any congenital abnormality, by any mean, if your myocardial cells get injury, then these three systems actually are the protective system in our nature, in our body, given by the God to protect the function of the heart. But the over protection and the over exertion and exhaustion of these system in our body, and without, if these system work in our body for a in a chronic phase or for a long term, then they would cause remodeling, and that remodeling actually causes these four things, and these four things finally causes what? Reduced ejection fraction. Now, cut in short, what would occur if your injury, if your myocardial cell encounters with any injury because of any cause, as we discussed here? What happened? There would be the activation of the sympathetic system. As you know that if your heart would get injury, the sympathetic system would start. The sympathetic system would start to work. So what it would cause? It was obviously due to the decreased stroke volume, because if your myocardial cell get injured, then the contraction, the contraction of the myocardial cell would get effect. Then obviously the contraction of the myocardial cell would get effect. Then it would give the less stroke volume and the less cardiac output. This less cardiac output actually triggers the activation of the sympathetic system. Then the activation of the sympathetic system causes what? Then the chronic activation of the sympathetic system causes the HFrEF, causes remodeling. The acute activation of the sympathetic system does not cause the HFrEF, because it is a protective mechanism in acute form, in the short term form, but in the long term form it causes hazardous effects. It becomes a vicious cycle for our body. Then it would obviously send signals to the rest, which is actually renal angiotensin aldosterone system. It would give the when it would get activated by the sympathetic system, then it would give certain messages to the juxtaglomerular apparatus of the kidneys. Then they would produce the renin. The juxtaglomerular cells activated by the sympathetic system would get information from the sympathetic system and start producing renin. Then that increased renin in our body causes what? It causes the cleavage of the angiotensin, normally circulating angiotensin in our body into the angiotensin 1. Then this angiotensin 1 by the renin, then renin further does what? It actually does that it convert the angiotensin 1 with the help of AC, angiotensin converting enzyme. It convert into angiotensin 2, and then angiotensin 2 does what? The angiotensin 2 actually increases the sodium resorption and maintain the stroke volume by increasing the blood pressure, because by retaining the sodium and the water from the kidneys. Okay, so this angiotensin 2 actually resorb the sodium and water. Now the problem, then renin does not stop here even, then it further activates to the aldosterone. Then aldosterone does what? Aldosterone start resorption again sodium and water, same as because what the angiotensin was doing, and it secretes the potassium out from our body. So it further resorping taking the water from the kidney. So in nutshell, this whole system is increasing sodium in our body to improve the blood pressure, and water to improve the preload and the stroke volume and the cardiac output. In acute system, this system, in the acute form, in the short form, this system is a very well protective and very well defensive for our body and very well managed. But if chronically this system affects if the chronically this system would get activated, then it would cause the remodeling and it would cause the HFrEF, heart failure with reduced ejection fraction. Now the third thing, last but not the least, other neurohumoral hormones releases in our body, in our endothelial cells, in our blood to causes what? Arginine. Vasopressin is an hormone which is released by the endothelial cells. It is an antidiuretic effect. Antidiuretic effect means it further takes water from the your kidneys and sodium. It further resorb the water and the sodium, so it further increases the blood pressure and stroke volume by resorbing this water. But chronically when it occurs, then your body would obviously swelled up, your body would get excess of water and excess of sodium. Now you have to address these things. Obviously all those things which prevent the remodeling actually gives the mortality benefit in the shape of pharmacological therapy. So here, by giving the beta blocker, we are actually doing what? Doing nothing, but we are just deactivating the sympathetic. The overactivation of the sympathetic system is halted by beta blocker. Is like we just give the beta blocker to cut or to deactivate the chronic activation of the sympathetic system in the heart failure patients. That's why beta blocker has a mortality benefit in the heart failure. Okay, now next thing what we do, these are the all class 1 drugs in our patient. Here by ACE and ARB, we just deactivating the RAS system, and by deactivating the RAS system we are actually preventing the remodeling in our HFrEF patients. Further, we give aldosterone in the low EF patients. In the reduced ejection fraction, you know that all aldosterone inhibitor drugs or potassium diuretic, especially spironolactone and eplerenone, are the class 1 drugs. Why? Because it further deactivating the function of the aldosterone, and here again it excrete the sodium and get the potassium in our body. So actually by these drugs we are preventing to get the sodium, excess sodium and excess water in our body, and by doing this we are actually giving a preventive remodeling or the protective mechanism, or we are just doing by giving these drugs we do nothing but we just do opposite of this pathophysiology of heart failure, HFrEF. Okay, so just keep remember that these pathophysiology is actually the remodeling, and we have to prevent the remodeling by these drugs. That's why it gives a mortality benefit to our patients. Now very important is that what are the stages of heart failure? How would, obviously, stages of heart failure, as you know that, as we will discuss in valvular, that stage A is always the patients in the stage A would not have actually structural heart disease, but they would always be at the risk to develop that disease. So at risk, just remember this with the one word, is that stage A is those patients who are at risk to develop that disease. That might be patients those like hypertensive, diabetes, valvular heart disease patients, or those patients who have a history of ischemic heart disease but with a normal ejection fraction. So these patients would be actually the patients with no symptoms but have no structural, not valvular or ischemic heart disease, because your patient would not have any valvular heart disease, but these patients would would have risk factors, or they are at risk to develop the heart failure or structural heart disease such as hyperthyroidism or anemia like. Now stage B. Stage B are those patients who are actually with the heart disease but yet not developed the symptoms. structural heart disease. So this heart failure could be diastolic with normal ejection fraction, and it could be systolic with reduced ejection fraction. Okay, so here we are discussing the only structural heart disease. It could be structural, structural could be dilated cardiomyopathy, structural could be restrictive cardiomyopathy. Okay, so but here is a structural heart disease but no symptoms. These patients would not have symptoms but only the structural heart disease. These patients would be absolutely asymptomatic. These patients would not have any symptoms at all, only structural heart disease. But the stage C patient, stage C patients are those patients who have structural heart disease plus symptoms and are on drug therapy, These are patients who might be like have a history of symptoms. Now they would be asymptomatic, but they in past or in present they they would be symptomatic. In one either they would have a history of symptoms in past or in present. Okay, so these patients remain stable on the pharmacological therapy and conventional therapy. So stage C patients are those patients who have a structural heart disease symptoms, but they are stable on conventional therapies. Stage D patients are actually advanced heart failure patients who are not despite of maximal or optimized medical therapy GDMT, they would need advanced therapy, advanced device therapy. So what would be the advanced device therapy here, like such as CRT or all these things. So stage D patients would be those patients who would need advanced therapy such as CRT, LVAD, heart transplant, heart lung transplant. So stage D patients would despite of giving the optimal medical therapy, they would need something else, they would need something more. Okay, now we will discuss here how would we classify our patients, the shortness of breath of our patients in the heart failure, in the reduced ejection heart failure, or any type of the heart failure. So we will divide our patients into 4 classes: NYHA class 1, NYHA class 2, class 3 and class 4. Simply remember only one word definition of these things. One is extraordinary. Extraordinary means if your patient is capable to walk 4 miles, 3 miles, 1 kilometer, 100 meters, 2 meters, 3 meters, but beyond that ordinary limitation, beyond that ordinary exertion, if he or she will do the exertion, he or she would have the symptoms of heart failures like angina or such as shortness of breath, dyspnea, anything extra on ordinary, anything or like doing of anything extra than ordinary would cause symptoms in an NYHA class 1. If your patient has to climb, if your patient usually climbs 1 or 2 floors daily, but now he or she has to go at the 3rd floor and she or he would develop the symptoms, then you will categorize him or her as a NYHA class 1. So anything your patient would do extra than the ordinary, you would categorize him or her as a NYHA class 1. But if your patient is doing the ordinary work which he or she used to do in the past, but now she or he is developing symptoms at that same ordinary work, that ordinary work might be for a fruit hawker, for the like it might be because of few patients, it might be 3 to 4 miles for few patients, and it might be 2 to 3 meters for our businessmen, like our patients who belong to sedentary lifestyle or sedentary professions. Okay, so it varies from patient to patient. You have to ask about their ordinary work. If they are doing extra than the ordinary and having the symptoms, then you would label them as a class 1. If they are developing the symptoms at the ordinary work which they used to do, then you will label them as a NYHA class 2. And if they are developing the symptom at the minimal exertion, means like bathing, changing the clothes, going to washroom. On minimal exertion, if they would develop the symptom, obviously then you will label your patient as a NYHA class 3. And if your patient has symptoms on rest, then you would label them as a NYHA class 4. I think I have made myself clear now.